So just want to welcome everybody to COVID and the Reproductive System. We're Erica and Jamie. We are fertility awareness educators and disability justice nerds who are really into COVID prevention. So we are going to go through our presentation. Feel free to drop questions in the chat, and we will have time at the end for Q&A, so we'll get to them at the end, or you can reserve your questions to ask live at the end if you'd like to do that. All right, so let's get started.
As a very brief overview for today's presentation, we want to discuss the COVID pandemic and the basic tenets of reproductive justice first, then dive into the research around reproductive health and pregnancy and COVID. Finally, we'll try to wrap it all up with a discussion on what we can do with this information, as well as pass on resources, and then hopefully open the floor to questions.
All right, so the first part we're going to talk about is the COVID-19 pandemic from 2019 to today. So why is this important now? Despite what you might be hearing or not hearing, we are still very much in an ongoing COVID-19 pandemic. And we know this because of wastewater data. Since most people are not testing anymore and certainly not reporting their tests to their county departments of health or what have you, wastewater has actually become the most reliable way to track spread. And that data tells us that there is still a lot of COVID moving through our communities. Right now, 1 in 52 people nationwide is infectious. That means in any crowded room, chances are very high that there's someone carrying the virus. In some places like West Virginia, it's 1 in 11, or Indiana, it's 1 in 16 right now. Connecticut, 1 in 35, Pennsylvania, 1 in 24. So in the week leading up to January 19th, this is all equivalent to about 6.5 million new COVID infections just in that week. And that can lead to anywhere from 301,000 to 1.2 million long COVID cases in that week. And 1,700 to 2,900 deaths will result from those infections from that week, just from that 1 week. Dr. Horger, he publishes updated data every Monday. And so you can check out this coming week, probably on Monday or Tuesday, he'll have that data up. And I have a little source down at the bottom here, pmc19.com/data, where you can always go check to see the latest updated wastewater data. At the same time, there's a study that was published in the journal Nature in late 2024 that shared that 400 million people worldwide are already living with long COVID. And this number is likely a lot higher today, over a year later. And approximately 20 million people in the US, including 5.8 million children and counting, are also suffering from long COVID. And actually, long COVID surpassed asthma as the #1 childhood chronic illness in the US in the last couple of years here. So that is making this long COVID one of the most common chronic conditions in the United States. And every new infection adds to that burden. So many refer to, let's see if I can zoom in a little here on the slide. Ooh, maybe over here. There we go. All right, many people refer to 2022 as the year when society gave up or when COVID ended, because the president, Joe Biden, at the time declared that it was over in a 60 Minutes interview without any evidence to support it, even surprising his own health advisors. And you can see that during COVID, a lot of people talk about during COVID is now, still now. We're in our 12th COVID wave at the moment. And you can see here, I can draw a little line, the lows keep getting higher. So even though we have this up and down each year, the low points are just slowly growing higher and higher. So even when we're in a lull, it's still, a lull today is still a lot higher than, you know, at any time it was here in this area during 2020. You can see from just this slide, like this is 2022, we've had a lot of infection, more transmission, more death and disability since COVID was declared over than before it. And this also really matters for children because spread is largely unmitigated in schools where a significant proportion of transmission comes from, and children are being infected once a year, sometimes multiple times a year. And here's where this all ties back to what Jamie and I heard talk about today. Those kids grow into teens and adults who may later face period pain, fertility challenges, reproductive health conditions that connect back to these early exposures. Every infection increases the risk of developing long COVID or systemic complications. And because the reproductive system is downstream of every other bodily system, disruptions upstream, even indirect ones, can absolutely ripple down to affect reproductive function and health. Okay, I just wanted to give you guys that perspective on where we are today in the COVID-19 pandemic. I'm gonna hand it back to Jamie.
So now we want to sort of frame this within reproductive justice. And it is important to credit Black women for the development of the reproductive justice framework. The term was first coined in 1994. As defined by Sister Song, it is the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. Reproductive justice and disability justice are inextricably linked. As having safe access to services and spaces during the ongoing pandemic is one way in which we uphold the third pillar of reproductive justice. And we also acknowledge as white women that we have a responsibility both to mask and encourage other white people to mask. Research shows racial disparities in COVID's effects and that it disproportionately affects Black communities, both in terms of health outcomes and economically. Research also shows that white people tend to care less about COVID and its impact when they believe it is not a white people problem. This makes it especially important for us to discuss this within our community of educators, especially other white educators who may not still be taking this pandemic seriously. Here you can see data from the Pew Research Center shows that 10% of white people mask at least some of the time versus 36% of Black people.
Okay, so we'll get into the reproductive health piece of this and the implications of COVID infection on fertility. So when we talk about how COVID-19 affects reproductive health, we need to start with where the virus can actually enter and act on the body. That happens through the ACE2 receptor, which is expressed in different parts of the reproductive system, as well as other areas of the body. In the ovaries, ACE2 is found in the granulosa cells of ovarian follicles, and these cells play a critical role in follicle growth and hormone production. So when COVID interacts here, it may disrupt folliculogenesis, the process by which eggs mature, and in turn influence overall ovarian function. In the uterus, ACE2 is present in the endometrium, the myometrium, and in the vascular smooth muscle cells. And that means infection or inflammation in these tissues could affect the menstrual cycle, uterine health, and even implantation potential. In the testes, ACE2's expression is actually very high. It's found in Leydig cells, which are responsible for testosterone production, and Sertoli cells, which support sperm development. And because of this, the testes may be particularly vulnerable to infection-related damage. Research does suggest that short-term reductions in testosterone and disruptions in spermatogenesis can occur after COVID-19 infection. And this helps explain some of the observed decreases in fertility parameters in men in the months following illness. So COVID-19 doesn't just target the lungs. It has multiple potential entry points into the reproductive system with implications for both male and female fertility.
Right. So as Erica touched on, there are different ways in which COVID infection can affect male reproductive health. First, it's been observed that in short-term studies, sperm parameters are affected by COVID infection, such as decreased sperm concentration. A systematic review and meta-analysis published in 2024 found SARS-CoV-2 caused reductions in ejaculate volume, sperm count, concentration, viability, normal morphology, and total and progressive motility. Researchers have found evidence that these outcomes may actually be a direct consequence of infection of cells in the male reproductive tract. It is also hypothesized that SARS-CoV-2 may lead to the production of reactive oxygen species that cause oxidative damage to sperm. So we might see some of that infection via ACE2 receptor, but also just oxidative damage due to infection. We're also beginning to see that the effect of even a mild infection may have long-term implications for sperm health. Researchers in 2023 discovered a statistically significant difference in semen volume, sperm concentration, sperm count, total motility, and live sperm numbers, pre and post-COVID. And what's interesting here is that was on average 200 days after the infection. So a lot of times when we're looking at the outcomes of studies, we're limited by the time, the duration of the study. And so here at 200 days after infection, they were still noticing these changes in sperm parameters. It remains to be seen how this affects fertility and how long those effects may last for some men. And this is by no means an exhaustive review of male reproductive health, but it's worth noting that researchers have also found COVID in testicular cells. Some reviews suggest an association between infection and primary testicular damage, as manifested in altered hormone production and worsening spermatogenesis. Infection is also associated with higher risk of erectile dysfunction. That risk was 27% in one study. One study out of the UK reported a twofold increased risk of reduced libido and ejaculation difficulty in long COVID patients. The literature points to the presence of viral particles in the erectile tissue as one cause. ACE2 receptors are abundant in the endothelial tissue, and COVID can bind and destroy cells from this entry point. It could, of course, also be related to long-term cardiovascular complications, and that's worth noting too. Reproductive hormones can also be affected by infection. As mentioned previously, that can be the result of testicular damage post-infection. Reduced testosterone to LH levels are found in COVID-infected patients, and researchers have suggested that as a result, COVID may lower the rate of spontaneous conception, as well as reduce the success of assisted reproductive technologies. One hypothesis for the drop in testosterone is that there's an increased sensitivity of the HPG axis to inflammation, and this could induce an acute and dramatic drop in circulating testosterone in COVID-infected men. Other researchers found that men display persistent low testosterone levels after COVID infection, reminiscent of absent or aberrant GnRH production. A review last year highlighted just under a dozen studies reporting lower testosterone levels after infection, with one study finding 50% and 30% of men still had serum testosterone levels consistent with biochemical hypogonadism at 7 and 12 months after infection. So this was a lasting effect that they noticed in their studies. And this discussion of testosterone flows really well into a discussion of a highly important paper published in 2023, Long COVID, Cognitive Impairments, and Reproductive Hormone Deficits in Men May Stem from GnRH Neuronal Death. And we'll have all the studies that we've cited in a reference sheet. This is an especially important one. Here, researchers investigated the hormonal profiles in brains of those who had had COVID to determine potential causes of long-term hypotestosteronemia or reduced testosterone in blood. What these researchers found was that GnRH neurons themselves were dying in all the patient brains studied, dramatically reducing GnRH expression. As fertility awareness educators, we are well aware of the significance of gonadotropins for reproductive health. Loss of GnRH neurons leads to reduced GnRH expression and perturbed secretion. In the case of men, leading to reduced testosterone. The researchers responsible for this study warn of, quote, a non-infectious pandemic of reproductive health disorders, end quote, in the future, following COVID neuroinvasion. GnRH neuronal death is irreversible, and GnRH expression could decline over time if active virus persists in the brain, as has been observed in some studies. So they found viral persistence in parts of patient brains, including in the hypothalamus, which we all know is so important for ovulatory health. Though the focus of this paper is on men's brains and fetal GnRH neurons, this obviously also has implications for overall fertility. As the authors state, the most obvious repercussion of a long-term decline in GnRH production, given the role of GnRH as the master molecule controlling the reproductive axis, is a delayed effect on fertility in both male and female patients who survive infection. They highlight cases from one of their own cohorts, as well as other case studies in a meta-analysis describing hypogonadism developed several months after infection.
Just to reiterate, those GnRH neurons were found to be dying in all brains studied. Okay, so next let's look at the ovary and how COVID-19 may directly impact ovarian health. So we know that SARS-CoV-2, the virus that causes COVID-19, uses the ACE2 receptor to enter cells, and these receptors are present in ovarian tissue, especially in those granulosa cells that surround and support the egg. There's also a partner protein that helps activate the virus's spike protein, which means the ovary is not only exposed, but potentially also quite vulnerable to infection. Researchers have described the ovary as a compelling possible target for COVID, particularly during the follicular phase when follicles are developing and preparing for ovulation. A study published in 2021 put it very clearly: the virus could negatively impact female fertility not only by blocking the normal action of ACE2, which is essential for oocyte maturation, ovulation, and corpus luteum formation, but also by directly damaging mature oocytes and ovulatory follicles themselves. Follicles rely on granulosa cells to grow, develop, and ultimately release a healthy egg. If infection or inflammation disrupts granulosa cell function, folliculogenesis can break down. That may lead to irregular ovulation or even anovulation, where you're not releasing an egg at all. And this doesn't just have fertility implications. Regular ovulation plays a role in hormone balance, bone health, cardiovascular protection, and overall well-being. So when COVID-19 disrupts ovarian function, it's not just about conception, it's also about the many ways ovulation supports long-term health. So let's consider the indirect effects on ovarian health. When inflammatory cytokines are elevated, which we see in COVID-19 infection, they can create oxidative stress in ovarian tissue. This stress damages the granulosa and the surrounding support cells that the follicles depend on to grow and mature. If the HPO axis is disrupted by illness or stress signals from the immune system, we all know this if we're working with fertility clients, we see this when people get sick, how the HPO axis can be interrupted. The ovary may not receive the right hormonal cues. That means the release of LH, FSH, estrogen, and progesterone can become irregular, and that translates into irregular cycles, impaired follicular development, et cetera, et cetera. Because COVID also acts as a neurovascular disease, it can compromise blood flow to the ovaries. Reduced ovarian blood flow means follicles may not develop properly, which again affects ovulation and overall ovarian function. And so while the virus has direct pathways into the ovary, these indirect routes through inflammation, hormone disruption, and vascular effects all converge to increase the ovary's vulnerability. When we turn to the endometrium, the lining of the uterus, researchers have found that it also can be affected by COVID-19. Infection reduces ACE2 activity, which also leads to a downregulation in several genes that are critical for embryo implantation. And infection also alters the local immune microenvironment in the uterus and impairs endometrial receptivity, impacting implantation and fertility. Moving on, there's something that feels really important to talk about, which is premature ovarian insufficiency, which refers to the loss of ovarian function before age 40. Clinically, we think of this as absent or irregular menstruation, elevated FSH and LH, and low estrogen, low estradiol. During the earlier parts of the pandemic, most of what we had were case reports suggesting that COVID might trigger ovarian dysfunction, but those reports were small. Now we have emerging cohort data. There was a 2024 Sicilian study that followed reproductive age women after COVID infection, and it found meaningful ovarian reserve changes. AMH dropped by about 27%, antral follicle count decreased, and both FSH and LH increased by roughly 13%. Importantly, the effects were more pronounced in people with endometriosis, suggesting COVID may interact with pre-existing vulnerabilities. What we don't yet know is the timeline, whether these changes are temporary or persistent, and how commonly they really progress to premature ovarian insufficiency. So at this point, the message is caution, monitoring, validation, right? When clients or patients come to us validating their experience, COVID infection may contribute to ovarian reserve decline in some individuals, and symptoms like cycle changes or new infertility deserve follow-up. And I'm actually going to pause here. I didn't put this in my notes, but I feel like it's really, really important. Anybody here who works with clients or patients, if asking a question on your intake paperwork about COVID infection history is not currently on your intake paperwork, put it there. Ask, Have they been infected with COVID before? How many times? When? These are really, really critical, important pieces of information for us to know, especially when people aren't necessarily testing anymore. You might have to ask a few more investigative questions. Well, when were you last sick? What was that like? They may not have been testing, right? We need to be a little bit more investigative and ask those clarifying questions. Okay. So COVID not only acts directly on ovaries or the uterus, but it may also disrupt the HPO axis, which Jamie talked a little bit about with the male reproductive health segment. The hypothalamus releases GnRH, signaling the pituitary hormones FSH and LH. If that upstream signaling is disrupted, cycles can become irregular or even stop temporarily. Emerging reports suggest that COVID-19 may affect this axis through two main pathways: direct neural effects, because ACE2 receptors are present in the hypothalamus, and indirect inflammatory effects. Here it comes again: cytokines and systemic immune activation altering hormone signaling. We don't yet know how common this is or how long changes last, but it reinforces the importance of monitoring menstrual changes and hormone patterns after infection. So things your client or patient may tell you after they've been infected. Bleeding becomes a frequent topic of conversation. Can become a big issue for some people. So COVID-19 has been linked to menstrual cycle disruptions, and researchers have described these using the FIGO classification for abnormal uterine bleeding, or AUB. First, there's AUBC, or coagulopathy. We know COVID-19 alters clotting pathways. Depending on someone's individual physiology, that could translate into heavier bleeding for some people. I would say, at least anecdotally, more of my clients tend to see that, or lighter bleeding for others. Second, there is AUBO, or ovulatory dysfunction. And because COVID-19 triggers immune and metabolic stress, it can disrupt that HPO axis. That can cause temporary amenorrhea or cycle irregularities. There's also some evidence of reduced AMH and increased testosterone levels after infection, both of which suggest impaired ovarian function. Third, we have AUBE, or endometrial dysfunction. So studies looking at infected patients have found indirect changes in endometrial gene expression. We see upregulation of inflammatory and viral response genes and downregulation of genes that are important for repair and implantation. This points to altered immune and vascular dynamics in the uterine lining that could impair normal menstruation. And finally, there's AUBI, or iatrogenic causes. Certain COVID treatments themselves can affect bleeding patterns. For example, dexamethasone has been shown to reduce blood loss in some patients. So also being aware that the treatment for COVID may change the way people experience their periods following infection. When we look at long COVID, and I don't know, we might mention this later, but I'm going to mention it here because it's on my mind. Our presentation today is really focused more on acute impacts, the impacts of acute COVID infection on the reproductive system. When we originally started this, we wanted to cover acute COVID, long COVID, and as we started to put this together, we're like, oh my gosh, there's too much. We can't possibly put it all in one presentation. So we're hoping to put together a part 2 on long COVID in the future, but we do mention it here and there throughout the presentation. So when we look at people with long COVID, these menstrual disruptions are reported even more often, including heavier periods, irregular bleeding, worsened PMS symptoms. A study in 2025, I think it came out in September, made headlines related to long COVID's impact on menstrual cycles. I even saw it in some more mainstream news media. We'd love to cover this all today, but we'll be doing that part 2, hopefully in the future. So COVID infection is associated with the increased risk of menstrual disturbance, especially in severe acute infection, in long COVID, and among unvaccinated individuals, which we'll get to in a little bit. Something else to mention here is that if you work with clients, again, right, you see these when you're asking about COVID infection on their intake form, because you're all going to add that now to your intake forms. Take a look at what they're experiencing, and if it falls into any of these categories, and if there could potentially be a reason that this is showing up now post-infection. All right. So let's briefly talk about what the research shows regarding COVID-19 vaccination and menstrual cycles. So large US cycle tracking studies found a very small change in cycle length, less than 1 day, around 1 day, most often after the second dose of somebody's primary series. At this point, most people have had their primary series, so we're really looking at, the new boosters that come out each year. But these changes typically resolve within 1 or 2 cycles, but could be up to 6 or 7 in others. People using estrogen-containing contraception were less likely to notice changes. A large 2024 systematic review that pulled together dozens of studies confirms this overall pattern. The most commonly reported changes were that small short-term increase in cycle length, about a day, heavier bleeding, breakthrough bleeding, even in groups who do not menstruate, like postmenopausal folks, those on gender-affirming hormones, changes in premenstrual symptoms, including cramps, with mixed findings across studies. Cramps are more commonly increased in adolescents. And biologically, this makes sense, right? Menstruation is already an inflammatory and hemorrhagic process, and a strong immune response, like vaccination, can briefly affect endometrial repair or coagulation pathways. Importantly, studies have also shown no significant changes in baseline reproductive hormones, FSH, LH, or estradiol, before versus after mRNA vaccination. This points to immune and inflammatory pathways, not to ovarian hormone disruption. Overall, these changes are real and biologically plausible, and they're generally mild and short-lived. The review also helps to clarify who is more likely to notice these menstrual changes. So there was higher reporting seen in people with pre-existing conditions, including endometriosis, fibroids, adenomyosis, PCOS, thyroid disease, history of heavy or prolonged periods. Higher BMI, smoking, and high perceived stress were also associated with increased reporting. Hormonal contraception appears protective, reducing reported changes by about 50%, and any hormonal medications at all by roughly 27%. Findings on prior COVID infection were mixed, and timing effects, like both doses in the same cycle, if it's your primary series, or follicular phase vaccination, were linked to small increases, whereas luteal phase vaccination were linked to a small decrease in length. And I have seen this personally in my own cycles. The bottom line here is that vaccine-related menstrual changes are typically mild, temporary, and self-resolving, and they are far less frequent and far less persistent than the menstrual disruptions we see after COVID infection itself. A broader takeaway, and one that matters for all of us, is that menstruation wasn't tracked in the original vaccine trials. And once again, that highlights how reproductive health is often overlooked in research design. So now let's turn to some of the clinical observations around COVID-19 in the menstrual cycle. So COVID infection itself has been linked to a wide range of changes in periods. Like we mentioned, irregular cycles, heavier bleeding, prolonged periods, sometimes missed periods. These are much more consistently observed and documented after infection than after vaccination. And several studies have shown increase in cycle length, spotting, or heavier bleeding post-infection, with the risk higher in people who experience severe illness or long COVID. These reported changes reflect possible ovarian dysfunction and are likely linked to both direct viral effects and systemic inflammation. So on this slide, and like I mentioned earlier, Jamie and I come from a fertility awareness background. So on this slide, let me zoom in here. Where's my mouse? Here we go. Oh my goodness, why is this working? I'm zooming in. Oh my goodness. Here we go. Maybe this will work. Oh my gosh. All right. Well, let's see if I can. I'd like to zoom in on this slide though.
I think people can zoom in. Oh, did you get it? Oh,
yeah. Good. Okay. So on the slide, you see their example of two consecutive client charts, fertility awareness charts. The chart on the top is from late 2020, when a client who I'd been working with had just begun working with me after self-teaching from taking charge of your fertility. You'll notice a high spike in temperatures at the end of her cycle. And that shift actually alerted her to the possibility of COVID even before she was testing positive on rapid antigen tests. In fact, I think on this day, this was November 4th, at the last day of her cycle, she tested negative, and she confirmed, even though she had this spike, which alerted her to test, and she confirmed the infection 2 days later, so around here, with a positive rapid antigen test at the beginning of the next cycle. And you can see in this following cycle, her temperatures stayed pretty elevated at the start of the cycle while she was still ill. And she was still testing positive on a rapid home test on November 16th, which is right here, still testing positive almost 2 weeks later, and didn't test negative until November 20th. So 2 weeks of testing positive and thus infectious during that entire time. This is, I think, a message that has been altered over the last 5 or 6 years, that you are still infectious as long as you're testing positive, not because you've just had it for 5 days. You're still infectious if you're testing positive. Her peak day and point of change were later than usual in this cycle, and her overall cycle length was thus longer, 36 days instead of her normal 29 to 30. And this is just one individual case, right? But it mirrors what we're seeing in the literature. COVID-19 infection can cause meaningful, noticeable changes in cycle parameters that people can see right here in their charts. So I did want to just share a bit of that charting with you. So far, we've talked about the direct ways that COVID can interact with reproductive organs, but it's also important to look at the indirect pathways, the systemic conditions that COVID can trigger that ripple down to affect reproductive health. So you can see here on the right-hand side, and I'll zoom in a little bit as well, images of different organs and organ systems and the symptoms and pathologies related to them from COVID-19. The big picture here is that even when COVID isn't acting directly on reproductive tissues, these indirect systemic effects can still cascade down to significantly impact menstrual health, fertility, and reproductive outcomes. We all think of the reproductive system as a river downstream, and COVID may not always pour directly into that river, but when it disrupts things upstream like metabolism, the nervous system, inflammation, the thyroid, all of that eventually flows downstream and changes the health of the reproductive system. I mean, we're seeing increases in the development of type 2 diabetes or insulin resistance following COVID infection. We know, those of us who work in this field, we know that that has an impact on fertility and reproductive health. Okay, Jamie.
Many of us work with preconception clients or patients, some who have tried for a while before deciding to learn fertility awareness. So I think it's important to note that the research indicates COVID infection may lower clinical pregnancy rates. A large IVF study published late 2025 found a significant drop in clinical pregnancy rates. So that was 28% in the COVID group compared to 55% in controls, as well as lower live birth rates. Research published just this month showed COVID infection negatively impacted pregnancy outcomes. And those researchers noted reduced clinical pregnancy rates, 52% for the infected group versus 76%, and reduced live birth rates. So these recommendations to wait 3 to 6 months after infection before trying to conceive come from various studies on the effects on the reproductive system that we've discussed so far. For instance, due to that decrease in sperm quality and quantity, some researchers offer the advice that to prevent adverse fertility results, it is not recommended that patients with COVID-19 infections have a pregnancy plan within 3 months. That allows for sperm to recover before conception. The longer recommendation here, that 6 months, comes from a study of 1,500 treatment cycles with embryo transfer at a university fertility center in Germany. Due to the increased risk of miscarriage following infection, the researchers recommended 6 months between infection and seeking fertility treatment. And so that increased risk for the infected group was 62.5% versus 26% for the control. The final section of the reproductive health portion of this presentation is going to cover the implications for COVID and pregnancy, both potential risks to the pregnant person as well as the fetus. Okay, so let's start here. It is very important to recognize pregnancy as a risk factor for severe outcomes of COVID-19. A COVID infection when pregnant increases risks of hospitalization, premature birth, and ICU admissions. Researchers note that, quote, it basically bumps pregnant women into a much older risk category, and mostly pregnant women look pretty darn healthy, so we don't necessarily associate that with risk for complications, end quote. An analysis published in BMJ Global Health based on participants in a dozen studies from around the world found, sorry, Erica, could you switch one for me?
Yeah.
Thank you so much.
Oh, sorry. Okay.
Yep. So an analysis published in BMJ Global Health based on participants in a dozen studies from around the world found pregnant women infected with COVID were nearly 8 times as likely to die as their uninfected peers, nearly 4 times as likely to require intensive care, 15 times as likely to require mechanical ventilation, and more than 5 times as likely to need any type of critical care. They were also more than 23 times as likely to be diagnosed with pneumonia and more than 5 times as likely to have serious blood clots. So here we can kind of see, this is from the CDC's pregnancy mortality surveillance system. In 2021, infection was the most frequent underlying cause of death, and COVID-19 accounted for 40.5% of all pregnancy-related deaths. In 2022, it accounted for 10%. So that rate began to fall and continued to lower again in 2023. Contributing factors here could be the dominant variant circulating during those years, vaccination becoming more available, and also prior infections. COVID increases the risk of a number of pregnancy complications. It increases the risk of preeclampsia by almost 2 times. Multiple studies show the odds of developing preeclampsia, particularly severe preeclampsia, and HELLP syndrome, are significantly higher among pregnant women with COVID-19 infection. Preterm labor and preterm birth, there was a 2 to 3 times increased risk with severe cases of COVID. Severe COVID late in pregnancy sharply increases the risk of preterm delivery compared to no COVID. As for stillbirth, a large Nordic study of nearly 400,000 births found COVID infection more than doubled the risk of stillbirth overall, 2.4 times higher risk compared to those not infected. The risk was highest shortly after infection within the first 2 weeks. Stillbirth risk was 5.5 times higher, and then it decreased down to about 2.4 times higher over the weeks past infection. And it is definitely relevant to fertility awareness clients that COVID increases the risk of miscarriage. This was most recently noted in a study in May 2025 that showed infection before or during pregnancy may increase that risk of miscarriage by 2 to 3 times. As COVID affects the body's vasculature, it's possible that it could affect the endometrial lining and contribute to loss that way. We should be very clear with patients who express an interest in a certain kind of birth, such as home birth, that avoiding COVID should be something they and their team are serious about, given that infection may increase the risk of miscarriage, hemorrhage, stroke, preeclampsia, placental rupture, and preterm labor. Pregnant patients may suddenly find themselves in the high-risk category. That means they need to reconsider where they will give birth. They may need a facility that has a maternal fetal medicine doctor present. And it may also lead to complications after birth that require being in a hospital to receive the proper care.
Okay, so you're probably all very familiar with images like this of healthy lungs versus smokers' lungs as part of anti-smoking and smoking cessation education over the past few decades. And we see this and we understand it. Smoking destroys lung tissue and its ability to function. It becomes harder to get the oxygen we need to breathe and to live. Here, we are looking at images comparing a healthy placenta on the left, collected before the pandemic, with placental tissue from people infected with COVID-19 on the right. The healthy placenta appears spongy and red, and by contrast, the COVID-affected placentas are stiff with dark discolorations from dead tissue. These images come from case studies published in the journal Viruses in 2022. The researchers found that even in pregnant women with mild COVID symptoms, the placenta showed striking abnormalities. Areas of infarction where tissue died due to lack of blood flow, fibrin deposits, the protein that forms blood clots, in the intervillous space and within the chorionic villi, disrupting nutrient and oxygen exchange. Calcifications and widespread inflammatory changes that are linked to growth restriction and pregnancy loss and associated with preterm labor, and signs of maternal and fetal hypoperfusion, meaning reduced blood flow on both sides of the placenta. And the important point here is that it didn't take severe COVID to cause this. Even mild infection was enough to produce these changes in the placenta. A 2024 study provided molecular evidence that even without detectable virus in the placenta, infection reprograms placental function. And these findings align with the clinical observations of increased rates of preeclampsia and fetal growth issues in COVID-affected pregnancies. So when we look at pregnancy outcomes, COVID-19 infection is associated with several important risks. Developmental outcomes. Infants exposed to COVID in utero may face developmental challenges. Some studies have described transient fine motor abnormalities likely related to the placental hypoxia and ischemia during infection. And a recent Nature study found that prenatal COVID infection was associated with neurodevelopmental delays in early childhood. And these outcomes were linked to changes in cord blood cytokine and chemokine patterns, suggesting immune signaling during pregnancy may play a role. So you can see here, it's showing different, the risk, the increase in cognitive delays at 6 months and 24 months of age across cognitive delays, communication delays, and motor delays. And you can see like communication delays at 6 months was at 20% and increased to 64% by 24 months of age. Beyond early developmental screening, researchers are now examining longer-term brain development in children exposed to COVID in pregnancy. One study comparing children born to infected versus uninfected parents found that at age 2, prenatally exposed children showed differences in regional brain volumes, including larger cortical gray matter and smaller white matter. These children were also more likely to score in ranges indicating developmental delay on standardized assessments and showed a higher risk of internalizing behaviors such as anxiety, depression, or other mood-related challenges at 2 years old. Importantly, these findings reflect associations, not causation. Multiple mechanisms may be involved, including placental immune activation, maternal inflammation, hypoxia, stress, and we don't yet fully understand how these pathways interact. So while this research is still emerging, literally I added this to the slide last night. Like this study just came out yesterday. While the research is still emerging and long-term follow-up is ongoing, it does suggest that in utero exposure to COVID may subtly influence early brain development, reinforcing the importance of ongoing developmental monitoring and supportive care for exposed children, and protecting our clients and patients as much as we can from our points of view from infection and pregnancy. When we look at fetal growth, the timing of COVID infection during pregnancy clearly matters. Infection during the first trimester has been associated with smaller newborn size, including lower birth weight, shorter length, smaller head circumference, and earlier gestational age at delivery compared to pregnancies that were unexposed or exposed later. So by contrast, third trimester infection has been linked specifically to reduced head circumference, even when babies are not otherwise small for gestational age. So if you remember from like a decade ago, there was another virus causing ripples in the news with infection causing microcephaly, the Zika virus. Similar situation here. Low birth weight is also a consistent finding and likely reflects that impaired placental blood flow and reduced oxygen delivery during infection. So when taken all of this together, COVID infection in pregnancy is not only a maternal health issue, it has measurable implications for fetal growth and childhood development, with the highest seen with early gestational exposure and more severe illness.
So just very briefly, we are indebted to Dr. Vicky Mail at Imperial College London for her comprehensive review of vaccination literature, and we'll make that explainer available. So she has the supporting literature that shows there's no difference in conception odds for those vaccinated before pregnancy. There's no increased risk of miscarriage with vaccination. It hasn't been associated with placental pathology. It reduces the risk of preterm birth and stillbirth. Stillbirth, very critically, all of the COVID-infected mothers who experienced stillbirths were unvaccinated, and maternal vaccination has not been associated with any increased risk of developmental delays in babies and toddlers. And so to very quickly wrap up, Erica, we just want to talk about the fact that a lot of COVID research as it pertains to fertility is non-existent. We have 5 pages of literature and still, we're barely starting to scratch the surface on COVID's effects on fertility. So it's really important to mention to our clients, not overwhelm them or shame them for whatever prevention they've implemented in their own lives. But if there's a client reaching out for information after becoming sick, for instance, we can give them helpful information about what they may see in terms of cycle changes, what they might expect in the coming cycle. If a client's looking to get pregnant soon and thinking of traveling, we might share resources on masking to help them avoid contracting COVID, especially during one of the waves. And if a client has expressed interest in learning more about COVID infection and pregnancy, so they and their care team can watch for warning signs of complications, that could be information we pass on to them. So it's all about context and just helping to create safer communities and giving folks resources. So we have very little data on the long-term effect of cumulative COVID infections on patients' fertility. There was just a study a couple of days ago published that showed half of pregnant women in the study who contracted COVID went on to experience long-lasting post-COVID symptoms. Interestingly, forgetfulness was the longest one, with participants still reporting it at 40 weeks post-infection. This is only going to become more important of an issue, considering that Dr. Horger's data estimates that the cumulative infections today is about 5 per person, which is roughly an infection a year. And okay, go ahead, Erica.
Okay. So when folks ask, what can we actually do? The answer is layers. There is no single intervention that is perfect, but stacking protections makes a big difference. And this image is one version of the Swiss cheese model of respiratory virus pandemic defense, categorizing the layers between personal and shared responsibilities. So personal and shared responsibilities. So on the left, we have physical distance, staying home if sick, masking, hygiene, avoid touching your face, limiting time in crowded places. And then the shared responsibilities, testing, ventilation, being outdoors and having air filtration, financial support, quarantine and isolation, and then vaccines. So with masks, wearing a well-fitting KN95 or N95 mask protects you and the people around you, especially because many infections spread before symptoms appear. I think it's something like, did I read something like 60% of infections spread asymptomatically or pre-symptomatically. Clean air, ask about ventilation and filtration, support things like Horsey Rosenthal boxes, which is like air filter you can build at home out of a box fan, in homes, schools, community spaces, in your own spaces, especially if you work with pregnant clients or clients looking to become pregnant. Make donations to your local mask block. Support local masking initiatives, encourage healthcare practices to use mitigation, and normalize policies that notify families when there's exposure. And then when planning events, advocate for remote options so people who need to be cautious are not excluded. And that's really the core of the Swiss cheese model. Every layer has holes, but layered together, they improve success and they work. This is a list of helpful resources for more information. And on the next slide, I have a QR code you can scan with to take you to the PDF. We'll also share that afterwards here. I'll pause this for a moment. And I guess just because we've got 10 minutes here to before we wrap up, I just want to invite you to reflect, right? Think back over what we covered today. What feelings came up for you? Was there something surprising, validating, maybe difficult? What's something new you learned you didn't know before you came in? And most importantly, how will you take this knowledge forward? Think that could be personally and how you think about your own health, or professionally in the way you support your clients and community. So thank you again, everybody, for showing up for this topic that doesn't get a lot of airspace anymore, but we appreciate having this opportunity to share more with you.
Thank you so much.
Thank you both. That was amazing. Does anyone have any questions for Jamie and Erica? Please, you have the floor. Just feel free to speak.
I'm also going to put in the chat a link to the resources page and a myths and facts page that might be helpful for you all.
And we have all the resources, like all the literature that references. That's what I was looking for. We have all the references. I actually have to add a paper that we had to last minute incorporate because the data on long COVID in pregnant women is really concerning. And before, there was a University of Texas study that showed it was 1 in 10 pregnant patients would go on to develop long COVID. And then this study published like January 20th showed that half of women were experiencing long-lasting symptoms. Yeah, question?
Thank you for putting this symposium together and this presentation to get together. I really appreciated a lot of the insights. And as somebody who's not in the medical field, I'm in the public health field who also menstruates. I've noticed that whenever I go to the doctor just to even get care, this is not on their radar. There's not much attention that they have paid for it, have been trained to pay for it. And when it comes to getting tests to investigate what exactly is going on so that way it can be addressed, it's sure, let's do a biopsy, make sure it's not cancer, but nothing else much. Yes, they might offer birth control, but it's not because they understand mechanically or what mechanisms are at play. So as somebody who is trying to at home it as best she can, what are there any specific tests that us as patients can advocate for? Are there any specific signs that we should pay special attention to? Because as someone who pre-COVID had a heavier period already, and then I've unfortunately had COVID 3 times, both on a plane or once when I was like, I diligently masked, but so I know my intake of the viral load was low. Like I got tested negative very early on because I was very quick about it, but there's having heavier periods before and then seeing that my body can do much worse after. It's hard to communicate to those doctors, hey, yes, this was like this before, but these are the new presenting symptoms. These are the new presenting like PMDD, clots like I've never seen before. So what are some things we can ask for? And have you guys also come across any remedies that are not necessarily medically promoted, but COVID has kind of been medically forgotten by some people, but have shown to be effective for those who are just looking for some kind of relief?
Yeah, first, I'm really feeling for you in the challenge working with the medical care system around getting adequate attention and care to your issues and getting somebody to not dismiss them. I would say as fertility awareness educators, treatments are out of our scope. So I can't specifically provide that kind of information. But if you share your contact with me in the chat, I can provide some resources that might be helpful, especially around how to talk to providers to get them to take a deeper look. If that's helpful, just feel free to either share privately with us over the chat or with Nicole, and Nicole can pass that to us. I'm happy to send you a little bit more.
Thank you.
Yeah. I think I see Taylor's hand up.
Yeah, I actually didn't have a question. So if there was anyone that did have a question, I didn't want to take time away from those who did. I just had an interesting kind of anecdote from this week that was relevant, that I found relevant possibly. So I don't know if anyone else had questions.
I don't see anyone. Oh, wait, hold on one second. There's
Our hand up, Riverview B&B. That sounds fun. I want to go there. If you have a question, if not, Taylor can share.
Okay. I do. Sorry, I couldn't find the microphone. I've seen very little information on how COVID affects menopause. I entered probably my last phase of perimenopause in 2020, and then March of 2020 missed my first period since adolescence, since I was like 14 or something. And I just don't see anything about how it affects the actual menopause. I know, certain things like it will, obviously, a lot of people experience cardiovascular symptoms after both the vaccine and the infection. And so that will obviously affect a lot of aspects of menopause, particularly hot flashes. But I've just never seen any studies. Have you guys?
I've started to so when I think about long COVID, I think a lot about perimenopause and menopause also, and wondering where they intersect. I've started to look for some studies and information around perimenopause and menopause and COVID. I've got a very small number, so I don't have a ton to share with you, but I can, again, if you want to pass along your info, I'm happy to share what little I have found.
Great. That'd be awesome. Thank you so much.
You got it. And Taylor, what was yours?
Yeah, so I heard this on one of my podcasts on Thursday, and I've been looking forward to the conference, and so I kind of filed it away as something interesting for this topic. One of my podcasters who's a professional athlete, she was revealing that she had been going through the past 6 months of basically nonstop menstrual bleeding to the point where she was having to get blood transfusions and things like that, and was so ill. And my first thought, of course, is, oh, did she have a COVID infection before this started happening? As someone who has paid attention over the last 6 years to COVID and seen a lot of, personal stories on social media of people who've, struggled with their cycles and excessive bleeding after COVID infection. But I just thought it was so interesting, her, shining a light on going to, doctor's appointments, no one being able to figure out what was wrong with her. Doctors really not being curious, waiting months to see a specialist, who then after the appointment doesn't even call her back. And still to this day, having no idea, what's been going on. But I was just astonished to hear 6 months of this persisting. And I think she just really, used her platform to kind of speak on what a lot of people have probably been struggling with because of how COVID affects the menstrual cycle. So I just thought that was interesting and relevant to the topic.
Yeah, absolutely.
Thank you for sharing about that, Taylor. All right. Any other last minute questions or anything? Yeah. Cool. Well, thank you, Nicole, for making the space for us here.
Thank you
so much.
Yeah, no, this was so much fun.